Ventricular fibrillation, VF, is a life-threatening cardiac arrhythmia characterized by rapid, erratic electrical impulses originating in the ventricles of the heart. This condition causes the heart to quiver ineffectively, leading to a cessation of effective cardiac output and, ultimately, sudden cardiac arrest if not rapidly addressed. Pathophysiology. 1. Electrical disorganization. VF occurs when the normal electrical impulses that control ventricular contraction become chaotic. This disrupts the synchronous contraction of the ventricles required for effective blood ejection. This chaotic rhythm typically arises from underlying myocardial conditions or triggers, such as ischemia or electrolyte imbalances. 2. Loss of cardiac output. The rapid, irregular activity prevents the ventricles from pumping blood efficiently, leading to circulatory collapse. This results in immediate loss of oxygen delivery to vital organs, including the brain, causing unconsciousness within seconds. Causes. 1. Acute conditions. Myocardial infarction, especially acute coronary syndrome. Severe electrolyte imbalances, e.g. hypokalemia, hyperkalemia, or hypomagnesemia. Hypoxia or ischemia. 2. Chronic conditions. Structural heart disease, e.g. dilated cardiomyopathy, hypertrophic cardiomyopathy. Previous episodes of ventricular arrhythmias. Genetic predispositions, e.g. long QT syndrome, Brugada syndrome. 3 triggers: use of proarrhythmic drugs, electric shock or trauma to the chest, commotio cordis. Clinical features. Sudden onset. VF often occurs suddenly without warning, though patients with premonitory symptoms may report palpitations, chest pain, or dizziness. Immediate effects. Loss of consciousness due to abrupt cessation of cerebral perfusion. Absence of a palpable pulse or measurable blood pressure. Respiratory arrest following cardiac arrest. 3. Diagnostic features, ECG findings, rapid irregular waveforms without discernible P waves, QRS complexes, or T waves. The rhythm is disorganized with varying amplitudes and frequencies. Management. Immediate acute phase. 1. Recognition and basic life support. Confirm cardiac arrest and initiate high-quality chest compressions immediately. Ensure early defibrillation availability. Avoid interruptions to chest compressions. 2. Defibrillation. VF is a shockable rhythm. Deliver a single biphasic shock of 120 to 200 J, or manufacturer-recommended setting, as soon as a defibrillator is available. Continue CPR immediately after shock delivery for 2 minutes before reassessing rhythm. 3. Advanced cardiovascular life support, ACLS. Establish airway and secure effective ventilation. Administer epinephrine, 1 mg IVIO every 3 to 5 minutes during resuscitation. Consider antiarrhythmic agents if VF persists. Amiodarone, first dose 300 mg IV bolus, second dose 150 mg if needed. Lidocaine, alternative to amiodarone, 1 to 1.5 mg per kilogram IV, then 0.5-0.75 mg per kilogram for subsequent doses. Post-resuscitation care. 1. Return of spontaneous circulation, ROSC. Optimize ventilation and oxygenation, target oxygen saturation 94%. Maintain hemodynamic stability with fluids or vasoactive agents, e.g. norepinephrine. Assess for reversible causes, e.g. H's and T's, hypoxia, hypovolemia, hydrogen ions, tension pneumothorax, etc. 2. Therapeutic hypothermia. Consider in comatose survivors of VF to improve neurological outcomes, 32 to 36 degrees for 24 hours. 3. Coronary intervention. Perform emergent coronary angiography if myocardial infarction is suspected. 4. Implantable cardioverter defibrillator, ICD. For survivors of VF at high risk of recurrence, an ICD may be implanted for long-term prevention. Rationale for management. 1. Defibrillation. Terminates the chaotic electrical activity by depolarizing all cardiac cells simultaneously, allowing the sinus node to reestablish its role as the primary pacemaker. 2. Chest compressions. Sustain minimal cardiac output to maintain vital organ perfusion during the period of electrical instability. 3. Medications. Epinephrine enhances coronary and cerebral perfusion pressure during CPR. Antiarrhythmics help stabilize myocardial excitability and prevent recurrence of VF. 4. Post-resuscitation interventions. Addressing reversible causes prevents recurrence. Advanced therapies like therapeutic hypothermia and ICDs improve long-term survival and quality of life. Clinical correlation. 1. Acute myocardial infarction. Ischemic regions create substrates for re-entry circuits leading to VF. Early reperfusion therapies, e.g. PCI, reduce VF incidence. 2. Congenital channelopathies. Conditions like Brugada syndrome predispose patients to VF, particularly during febrile episodes or drug exposure. Early detection and ICD placement are life-saving. 3. Hypokalemia or hypomagnesemia. These electrolyte abnormalities increase myocardial excitability and predispose to VF. Prompt correction reduces arrhythmic risk. In conclusion, VF is a critical emergency requiring swift recognition, defibrillation, and comprehensive post-resuscitation care to improve survival outcomes. Clinical management should be tailored to the patient's underlying condition, emphasizing the identification and treatment of reversible causes.